Hello, everyone. We are excited to have you with us for this webinar. My name is Joshua Kroll, and I'm the Director of Sales and Marketing with Avexia Diagnostics. I want to welcome you to this presentation regarding coagulation testing. I'm joined by my colleague, Dr. Wayne Sedano, the Director of Clinical Support and Education with Avexia Diagnostics, and a very special guest, Dr. Brian Poirier, who will be discussing some key benefits and details of coagulation testing performed by LabCorp. Now, Dr. Poirier is a diplomat of the American Board of Pathology in Anatomic and Clinical Pathology, as well as in transfusion medicine. He currently serves as the CLIA Medical Director for LabCorp specialty testing in Calabasas, California, and Denver, Colorado, as well as the Director for Immunohematology, Coagulation, and Acute Care Testing for LabCorp. In addition, Dr. Poirier has a passion for teaching and serves as volunteer clinical faculty at the Penrose St. Francis Residency Program. His lab leadership experience includes academic laboratories, large hospital-based practice, and over 8 years of service with LabCorp reference laboratories. Dr. Poirier holds membership in the American Society for Clinical Pathology, the College of American Pathologists, the American Association of Blood Banks, the American Society for Apheresis, and the American Society of Hematology. Now, without further ado, Dr. Brian Poirier.
Great. Thank you very much, Joshua, for that introduction. And thank you for inviting me. It's a real pleasure to join you all tonight and discuss coagulation a little bit. As Joshua mentioned, I'm a pathologist by training in AP and CP pathology, and I've worked in both the hospital and reference lab setting and also in the community blood center. But I've focused most of the last 10 years of my career on coagulation and blood bank testing. So really excited to be with you to discuss that a little bit and discuss our lab in Denver, where we do the coagulation testing as a specialty testing lab for LabCorp. Oh, sorry about that. There's just a bit of a delay in my slide advancement. There we go. So tonight I'd like to talk briefly with a little bit of introduction to coagulation testing. And then I thought it would be good to discuss 3 of our most commonly ordered panels. And also, these are the panels I get the most questions on from clinicians, from nurses, from other laboratories to get their help. And then I'll do a little summary at the end. And I know Joshua has a few slides after me to present tonight. And I apologize to Joshua. I do have a hard stop at the top of the hour. I'm doing, Joshua mentioned the College of American Pathologists, and on behalf of the CAP, I'm doing an inspection, a remote inspection in China, interestingly enough, this week. That starts at 6 tonight. So I'll have to be off for that. So my apologies. So Joshua also mentioned that I teach the residents. I try to bring a Starbucks gift card or something in with me if they can answer my questions. And so one of the challenges I give them is, can you name all the pearls in this slide? And so far, nobody's got 3 out of 3 yet. So I'll let you chew on that. You can give your answers to Joshua. So this is kind of what I think about every day in the laboratory. In training, we often are shown the coagulation cascade. But really in vivo, the coagulation cascade doesn't do a very good job of representing what happens in vivo. And the idea, of course, of forming a clot is that you want a a solid to form around a break in the endothelial cell layer, and that solid form not to carry on beyond the point of injury. So this needs to stay fluid on the right side of the diagram while forming a solid clot on the left side. And there are a number of ways that the body does this. And the only proof I have that this crazy system works is that we're all here today and listening to this. It's quite an incredible thing. But in our lab, we both do clinical testing and we also do clinical trial testing. And we've dealt with almost every protein and antibody on this diagram. So to give you an example, we're looking at an inhibitor of antithrombin. And so why would you want to inhibit antithrombin? Well, as you can see, if you inhibit the antithrombin, which then is designed to inhibit thrombin, which is the major driver of the fibrin clot formation, that'll give you a prothrombotic state. And the reason it's useful, and we're doing clinical trials around it, is that for folks with hemophilia A or B, deficiencies of factor 8 and factor 9 respectively, anything whereby you can increase the prothrombotic mechanisms will help to balance out the bleeding risk you have from hemophilia. And so that if you're able to offset the bleeding risk that is engendered by factor 8 and 9 deficiencies, you might be able to balance this picture out. And indeed, that's exactly what happens. And the other advantage to that, as an example, is that, as you probably know, kids with severe hemophilia A or B, when you give them a replacement of factor 8, say, one of the problems is that they can form an inhibitor to factor 8. Well, if you're able to use antithrombin, you completely go around that issue of the factor 8 inhibitor formation. So it's a neat trick. And as you can see, it'll work on both factor 8 or factor 9 deficiencies, because all you're doing is increasing the thrombotic state in this balance. So we do a lot both with the diagnostic side of testing and the clinical trial side. And it's quite a fun lab to work at for that reason. Now, the residents always hate it when I show the coagulation cascade that we learned about. So we developed a simple diagram of probably more reasonably what happens in vivo rather than in the test tube. But I will show the clotting cascade later on in this slide presentation. But the point I want to make here is simply that in the lab, we're missing a major part of what happens in vivo, and that's the cell surface, particularly of the platelets. And so when the platelet clump forms, one of the things that happens with the activated platelets is that flipases are activated that will actually flip certain of the phospholipids in the cell surface from the inner to the outer surface. Phosphatidylserine is the classic one that does this. And it's important because that negative charge on phosphatidylserine that was on the inner surface then flips out. This surface gives an important milieu for the clotting factors to aggregate. And that helps along this propagation process that happens within the platelet clump. And so there's always a little bit of activated factor 7 floating in the plasma. Factor 7, along with tissue factor, will activate the initial generation of thrombin. And thrombin is a very active particle and activates many of the clotting factors. This feeds back into this loop that happens on the platelet surface and propagates that. And tissue factor is what really drives it, and that is released from the subendothelial layer. So you get a little bit of initiation at first. The more tissue factor you have around, the more initiation you'll get, and eventually you'll hit a critical mass that'll lead to propagation and fibrin clot formation. So what I'd like to do is talk about a few of the panels that we offer that are like I say, are most used, the panels I do the most clinical consults on. And one of our highest used panels is for von Willebrand disease. So I'd like to start there. And I'd like to use these panels to illustrate what we do in the COAG lab and how we think about these panels, because we like not to just put out the results, but actually to think about what we're seeing. And we've trained our technologists to be able to assist us, really assist me in this process, because they'll catch things that they'll bring to me, and we'll be able to work through issues together, and then with me consulting with the clients. And this is a very important process for us. And it's also something I really emphasize with the trainees, that you can't just put out results. You really need to think about it. And when necessary, you really need to reach out to the clinician, because the only way you can solve some of these cases is to know the clinical history. And pathologists sometimes tend to be a little bit introverted, so I'm always encouraging the trainees to get on the phone and call the clinicians. It's really important. So I'm showing this slide. It's a little too small to really see well. But the point is to show you that there were, in this year, new guidelines released for von Willebrand disease by the American Society for Hematology. And they're really an update on, they haven't changed the basic criteria that have been around for quite some time, which are shown here. I'm going to flip back. But they just added some modifications. So they are stressing the need to do a careful bleeding assessment. And there are several tools out there, risk calculators that are basically questionnaires, and help guide this. And they're sort of emphasizing that if the risk of von Willebrand disease is pretty low, your yield for doing a von Willebrand study is going to be pretty low too. So they're sort of emphasizing to rule out von Willebrand disease, that you can rule it out without necessarily having to do a full panel workup. A couple of the other things that they've emphasized here are, for many years, the criteria, which are somewhat arbitrary for von Willebrand disease, is that the antigen or activity level falls below 30% activity. In general, factor activities range from 50 to 100%, but it's based on local population studies. But in this new guideline, they allow for the diagnosis of von Willebrand disease if the von Willebrand factor is abnormal, but not below 30%. So generally, that's between 30 and 50%. So if you've got a strong clinical history and low von Willebrand factor levels, but not necessarily below 30%, ASH is saying, well, you can still make the diagnosis of von Willebrand disease with that. That's the main thing I want to show here. And also that they have sort of a cascade of testing that they recommend. And that is basically how our panel is built. Although our panel came out before this guideline, it fits very neatly into this update. And this is our panel, so it's that's the order number, and I'm sure Joshua can help if anybody needs help ordering this. I think he's got a slide about ordering. But what we do is we start, much like the cascade I was showing the last slide, we start with the basic von Willebrand levels. So we have an assay for measuring von Willebrand activity and the von Willebrand antigen levels. So what we're looking for is, are these low and are they concordant? Generally, protein deficiencies of a type 1 nature you simply don't have enough of the protein. In type 2 deficiencies, you may have enough of the protein, but it's not working appropriately. So you've got a qualitative defect, and that's what we're looking for. And we also order factor VIII activity because factor VIII is carried in the bloodstream by von Willebrand protein. And so we want to know what the factor VIII activity is as well, because it can be affected by von Willebrand disease. If the von Willebrand levels meet a certain criteria, either they're below a certain threshold or the ratio is low, then we do additional testing. And we add another activity assay, and that's for me basically to confirm the original activity that I did. It can give me some clues as to the diagnosis. So we run a collagen binding assay. And then we do multimers, and I'll show you a picture of what a multimer is. And then from that whole gestalt, we generate a diagnosis or suggest further testing. And with this panel, if there's any abnormal results, there are two pathologists, including me, who write the interpretations for these, which sounds like a lot of work at first, but fortunately most of these for us, for the lab, most of the initial order is normal. So most of these are ruled out with the screening, and they never get to this cascade. We expect that. So this is just the same thing, just written out if you'd like to see it in a different format. So we start with these three assays and then reflex as necessary. And then the pathologist reviews any abnormal results. So to review that for you, I'd like to walk through a case that we had pretty recently. It was a 20-year-old gentlewoman. And unfortunately, at the reference lab, as opposed to the hospital lab, I rarely get the clinical background. So I just start out with numbers. And so here's the patient. And it turns out the text noticed actually that there was a patient with the same name at the same time. Looked like the ages were probably father and daughter, and that's how it turned out. But as you can see, the antigen is low. This is our initial von Willebrand activity. The RCO stands for ristocetin cofactor. So the way we do the activity, it's very hard to replicate the function of von Willebrand protein in the lab, in vitro, because the protein sort of unravels in the circulation. It gets tethered, and then the circulatory forces sort of unravel the protein. It's a big multimer. And that opens up binding sites for the platelets and for the underlying subendothelial surface. And so how do you replicate that in vivo? It's very difficult. And the reagents we use are basically platelet clumps, little pieces of platelet. And then the ristocetin is an old drug that was found to actually help open up the binding sites in vitro. So we use that to replicate what happens in vivo. Somewhat imperfect, but once you get used to the patterns of the testing, you can work with it. So the bottom line here is that it's a little askance. So it's too low, and the ratios are abnormal to normal. And so this is just an odd result. Seeing a lot of these every day, this is a very unusual pattern. If this result and this result were a little more normal, I would just call this a type 1. So in type 1, what you usually see is the antigen maybe is 28%, and the von Willebrand activity is 26%. They're concordant. Both for the father and the daughter, they have a very similar pattern, which is, I guess, good in a way. It kind of confirms that these numbers are probably right, that it's not a sampling error, there's not a transport issue with the sample. They match pretty well, actually. So the next thing we do is the multimers. And it turns out in the qualitative defects, which are type 2 von Willebrand disease, what often happens is as the von Willebrand protein is being made in the cell, it's stacking in the cell. And it's the very largest multimers, these stacks of protein. It stacks on itself into these little protein clumps. And it's the largest multimers, these protein multimers, that really do the bulk of the work in vivo. So the big multimers, which are up here, bind platelets very well. The smaller multimers, not so well. In fact, if you have very large molecular weight multimers, which is abnormal, that's a condition called TTP, and a discussion for another time. But for a normal, healthy individual, it's these high molecular weight multimers that are doing the work of platelet clumping in vivo. Now, in type 2, what can happen is either the multimerization process in the cell doesn't work very well. That's type 2A, so there's some subtypes of type 2. Or sometimes, if the multimers are too sticky because of a genetic variant in the von Willebrand binding site, they stick to the platelets too well. Well, it's those large sticky multimers that stick way too well and they get cleared out of the normal circulation. So they bind platelets when they shouldn't. Those platelets get cleared and you're left with not enough high molecular weight multimers. So that's what I'm looking for on these gels. This is basically a Western blot. So what you're looking at here is you load the gel up here on the top. You apply an electrophoretic pull across the gel. It's an agarose gel. And the protein based on size will run through the gel quicker or faster. The big ones run slower, so they end up here at the beginning. And the smaller molecular weight ones run through very fast, and then we stain it. And that's all this is. So 12, 13, 14, and 15 lanes here are just normal, healthy individuals. So what did we see on our patient? And I'm sorry, the picture of the actual gel is not as beautiful as my standard ladders over here. But in gel 7 is the patient. This is a 2B control, so this is a type 2, and you can see not enough high molecular weight multimers here. This is just a control normal in the middle. It's actually, if you look at enough of these, it looks basically normal, but maybe a little, missing a little bit of the bands right on the top here. I don't know, it's really close, so it's subtle, but pretty close to normal. And give me 1 second, the slide isn't advancing. There we go. So what do you do at this point? So it's really important, and I do this almost every day, is call the clinician on some of these cases. So it turns out this was a 20-year-old lady who had come in prior to outpatient surgery. The clinician had gotten a story from the father that he had von Willebrand disease, and he said that they had 2A von Willebrand disease. That was the story. That was their diagnosis. And the clinician was trying to confirm this. Well, this doesn't look anything like type 2A on the multimer. It looks like a fairly normal multimer. Type 2As are very obvious on this study. And I can tell you, by the way, that the father and the daughter, their multimer look the same. So I was suspicious of 2A for that reason. I'm just showing the multimer again. So what I encouraged was, and just to review, in type 1, as we said, you're going to have low levels of von Willebrand. Factor VIII kind of does its own thing because it's not released by the endothelial cells the way von Willebrand is. It's made in probably the Kupffer cells of the liver. So it's got a different production mechanism. And although it's carried by von Willebrand protein in the bloodstream, it doesn't always show perfect concordance with the von Willebrand levels. It's roughly the same. So in type 1, you'll see low von Willebrand levels, low or even normal factor 8. The multimers are normal, and the ratio between these two is normal. Doesn't quite look like what's going on here. In 2A and 2B, you'll see an abnormal ratio, but they have fairly distinctive multimer patterns. The one that catches my eye for this case is type 2M. So there is an M stands for multimer. There's a subtype of type 2. Well, you get an abnormal ratio, but the multimer is normal. And so what happens is the multimerization is normal, but because of a defect in the binding site with the platelets, they don't bind as well as they should. So what I encouraged was to get genetic testing to be sure, because we've got a discrepancy here. We've got a history of type 2A in both the father and the daughter. We've got a clinical presentation that fits with it, but lab tests that don't jive with it. And so it turns out that both the father and the daughter had a novel, not reported previously in literature, genetic variant in right next to a previously reported 2M variant that was known. So this all fit nicely together. The variant was probably a autosomal dominant variant that was similar to what was reported before. And so the case fit nicely together. So this is actually not an unusual example where the clinical history and the diagnosis that's going into the case doesn't quite jive with what we're seeing in the coag lab. And sometimes it's quite subtle. So really important for us in our lab to make sure we're reaching out to the clinician. And again, just to review the panel that we recommend, we have more than one von Willebrand panel, but this is the one I generally have folks start off with. There are a couple ancillary studies I'll mention very quickly, particularly for type 1 disease. Often the next step is to see how they respond to desmopressin. A lot of folks with type 1 respond well and do well with desmopressin, but it's good to challenge them to make sure it works before procedure. And you can order that directly, kind of like a glucose challenge. And then we have a genetic panel. We actually have a genetics lab that does NGS testing in Atlanta, and that's where these are run. And I'll move on to one of our next most common panels, probably our highest panel by test volume, which is antiphospholipid antibody workups. So antiphospholipid antibodies, just to review, they are autoimmune antibodies, immunoglobulins that are directed against some aspect of what I had shown before. And I'm going to pop back really quickly to this slide. And highlight prothrombin, which is factor 2, being activated by this prothrombinase complex. We call it factor 10 and 5. Thrombin. This happens on the cell surface, and I mentioned phosphatidylserine. Often these antibodies are directed at a kind of a combo of the protein and the phospholipid. So they're kind of directed at factor 2/phosphatidylserine, some epitope that's recognized between a combination of those two. And in vivo, this gives you a prothrombotic state, these autoimmune antibodies. In vitro, it does something a little different. And I'm going to scroll back down. In vitro, what happens is we try to replicate that milieu of phospholipids, coagulation factors, and an acid-base ratio that allows the clot to happen. But in vitro, that mix isn't really replicating what we see in vivo. And in vitro, what happens is those antibodies actually prolong the clotting time. They interfere with the in vitro clotting we see in the lab. And so instead of what looks like a prothrombotic state, we see what looks like a bleeding state. And so it prolongs the PTT. And you might ask, well, if it prolongs the PTT, which is basically just some prothrombotic reagent, like a thromboplastin, we add some calcium, we add the phospholipids, and we let it clot. Well, why shouldn't it prolong the PT? And the answer is sometimes it does. It depends on the reagent. But typically the milieu of the PT, we use a lot more phospholipids in that mix. And these antibodies tend not to affect the PT as much. And in fact, the PTTs are often manufactured in a way that they're intentionally sensitive to lupus anticoagulants because we want to see them. The other way we try to identify these antibodies is through ELISA reaction. So basically plating the antigen of interest and putting the patient's serum or plasma on top of that little plastic plate and seeing whether any antibodies in the serum or plasma bind to the antigen on our plate. And then we detect it by some sort of luminescence. So those are the two ways that we're doing that. So there's one of the antigens we use is anticardiolipin. Another one is beta-2-GP1 antigens. And that mimics the antigen in vivo. And so the criteria for antiphospholipid antibody syndrome is both clinical and laboratory. So we've got the laboratory end, but not so much the clinical end. And so another reason I often call on these cases, if I see something that doesn't quite add up, I want to know the clinical history. So clinically, you need to have some history of venous or arterial thrombosis or pregnancy morbidity. And in the laboratory, you need to have at least one of those two assays I mentioned, a lupus anticoagulant assay or a ELISA-based positive assay. And I'll talk a little bit about how we do these lupus anticoagulant assays. So our profile for this is listed here. We actually have several profiles for this based on clinical need. But this is the one I think is most guideline-based and the one I typically start with. And this is how the report looks like. I think we're showing this just to highlight that our contact number is usually on the report itself. This particular one, has my name and phone number on it. So I can't hide, it's right here. But hopefully that's helpful to our clinicians to be able to know who did the report and where to call. Not all the reports that we do in coagulation look exactly like this, but more or less. So to illustrate one of these panels, here is a young 15-year-old, which is an unusual age for us to get an antiphospholipid antibody panel. It's typically in older individuals, not pediatric populations. Turns out I didn't know this at the time. The hematologist was actually evaluating for ITP. So we do the basic screening assays are included in this particular antiphospholipid antibody panel. And you may wonder why, because we're looking for very specific assay results. But it turns out that these screening results can give me and the other pathologists and the technicians a lot of clues as to what might be interfering with our panel, or what might be happening clinically. So for an antiphospholipid antibody panel, if there's a lupus anticoagulant present, by definition, it will elevate the PTT. And this PTT is elevated. It typically, as I mentioned, will not elevate the PT. So this gives me my first clue that something isn't maybe as straightforward as going on here. The throttling time is basically our measurement. We do it for two reasons. It's a measurement indirectly of the fibrinogen level, which a low fibrinogen may be missed by the PT and the PTT, but usually is not missed by the throttling time. It's the most sensitive to fibrinogen abnormalities. We also order it in our lab because we want to know if there's heparin in the sample. And the throttling time is very sensitive to detecting heparin in the sample. And that's good for us to know. We actually have an enzyme that will neutralize heparin in the sample. And so the throttling time will help us sort that out. So this sample does not have heparin in it. So then we went ahead, we did the antiphospholipid antibody panel that was ordered. And I'll just tell you, this is a very positive panel. So here's the anacardiolipin antigen that we run by Elisa, that plate method I mentioned. And we do both IgG and IgM antibody detection and beta-2 GP1. And so both the IgG phase was positive, and the DRVVT and this state clot LA are our two lupus anticoagulant assays in this profile. And essentially what you're doing is you're using one of two reagent milieus. So you've either got basically a PTT reagent, which is what's called state clot. It's basically a modification of a basic PTT. So it uses the same activators, the same phospholipids, basically. The DRVVT is the second one we use to increase our sensitivity, and it uses a snake venom, Russell viper venom. And it starts with a diluted form of the reagent mixture. So we use a diluted form of the phospholipids. And what that does is it enhances the sensitivity to these antibodies in the test tube. And if the screen is elevated, then we do a second test, and actually it's the seconds aren't shown here. But what we do is we add in, on the second step, we make the milieu very rich in phospholipids. And that's the difference between the screen and the confirmatory test. It's simply basically the amount of phospholipids you add. Because what will happen is, if this is elevated due to autoantibodies to a phospholipid, if you add in a whole bunch of phospholipid, it'll sort of correct this number. And then we do a ratio of before and after. So say the second number was 60 seconds. This is all in seconds. Then you take the ratio of the two, and that's the number we care about. And I'll just tell you that 2.5 is a very high ratio. And so it really suggests the presence of a lupus anticoagulant. And the more of these assays that are positive, the greater the prothrombotic risk in the future. And this one had all three of our assays positive, so we call that a triple positive. Now, why was the PT prolonged? So that's a bit of a conundrum in this case. The lupus anticoagulants typically don't prolong a PT, and I found out that part of the reason they were working this up, trying to figure out why the PTT was elevated and doing a lupus anticoagulant study, was actually because the patient was bleeding, not because he was clotting. So kind of odd. Well, the PT is generally a test, and this is the coagulation cascade that probably all learned. PT is very good at picking up factor VII deficiencies. And then for both the PTT and the PT, They're less sensitive as you go down the cascade here. So for example, PTT is very good, very sensitive for factor 12 deficiencies. So a factor 12 deficiency will cause a very elevated PTT. Similarly here, a fibrinogen deficiency, the PT won't elevate all that much with a fibrinogen deficiency, but it'll elevate quite a bit with a factor 7 deficiency, factor 10, and that's why we use it for, say, monitoring warfarin. So these factor 2, factor 5, factor 10 are the common pathway inhibitor factors because they'll affect either the PTT or the PT. So when I think about a prolongation of both of these screening assays, a number of things come to mind. One of the main ones is these days is direct 10A inhibitors. These newer oral anticoagulants can prolong both. I have no reason to suspect that in this case. We knew the patient was not on warfarin, but warfarin typically won't prolong the PTT that much. And we have another reason, which is the lupus anticoagulant, for the PTT to be prolonged. So we're kind of going down a different path. Just to be sure, though, because the patient was bleeding, we ran the basic intrinsic activity factors. Maybe the patient has a hemophilia that wasn't diagnosed, but those are all normal. We kind of have experience with this, so we knew we might want to try a factor 2 because that's prothrombin. And it turns out that these autoantibodies are often directed at factor 2. And it turns out it was very low in this young boy. And so we also made sure we ran a Bethesda titer, which is our inhibitor assay, to see if there was an identifiable inhibitor, and it was negative. And so it turns out the diagnosis in this case is hypoprothrombemia due to a lupus anticoagulant. Because rarely these autoantibodies that are directed at least partially at factor 2 will actually clear factor 2 from the circulation. And so these patients can present with bleeding rather than clotting. And we just by experience, we kind of, if we have any suspicion at all and we see a prolonged PT, we'll often run a factor 2 to be sure. And we kind of do that we did this without the client ordering it, kind of run it on the side as a quality measure and often make the diagnosis first. So it's not a neutralizing antibody, but it's a clearing antibody. The last panel I want to go through very quickly in the last 5 or 10 minutes here is I think one of our most useful panels, particularly for the hospital clients or small clinics that might have a small lab that can do a basic workup, but may need more help, is our abnormal screening workup. And what we do for this is, let's say the local lab has a elevated PTT and they're not sure why, there's no lupus anticoagulant, and they sort of run out of their local options. There's one order that they can order. They don't have to order a series of things, but just one order that says, hey, help me figure out this abnormal PT, or I'm seeing all 3 are elevated and they're not on an anticoagulant. I can't figure out why. And then we reflex as necessary in our lab. So for example, here's a 45-year-old woman who had a very elevated PTT. The PT and throttling time were normal. The platelet count was normal. And I guess I've left my resident pimping questions on here about what they might do next. And this is kind of a classic board question. So I'll just let you think about that. But from our end, we just saw a very elevated PTT, normal PT, and thrombin time. So very quickly, just as a review, the PTT is very good, as I mentioned, at picking up intrinsic factor deficiencies. A deficiency, say, of factor 12 or one of the contact factors, high molecular weight kininogen, for example, will really elevate the PTT. So when we see a very elevated PTT, sometimes we'll run a factor 12 activity just to see. As I mentioned, it's less sensitive to, as the further down you go in the cascade. less sensitive to factor V or fibrinogen. So probably not one of those in this case. So there's a number of things we think about, kind of listed here, listed out in order here. A lupus anticoagulant certainly could elevate PTT quite a bit. You can get spurious elevations. We see that less often when the PTT is that elevated and the PT and thrombin time are normal. Often in anticoagulants, especially these days, I see a slightly elevated PTT very often because rivaroxaban or apixaban will slightly elevate the PTT, and warfarin will do it. But typically, we also see a little bit of an elevation in the PT as well with those. So I'm really thinking along the lines of a factor deficiency or a lupus anticoagulant, particularly a factor 12 deficiency. So what are the next best studies to do? And I wanted to spend a couple minutes, and I've already mentioned these diagnostic considerations, talking about one of the next most important studies we do in the COAG lab, which is our mixing studies, where we simply take normal plasma and mix it 1-to-1 with the patient's plasma and see what happens. So if I mix typically with a factor deficiency, 50% normal plasma will correct the deficiency. So if I've got 10% factor VIII activity in the patient sample, due simply to a deficiency, and I add back in the normal factor VIII from the normal plasma, the PTT will be normal. So for the most of the factors, you don't need 100% of the factor activity to have a normal PTT. Just 50% will do it. So what we're looking for here is inhibitors. So what will happen is the inhibitor in the patient plasma will inhibit the normal factors in the normal plasma, and the PTT won't correct all the way. And that's what we're looking for. So we see this with, as I mentioned, in hemophilia A, these kids can get inhibitors to factor VIII replacement product. We're looking for that, or any of the factors. Sometimes they can even develop factor inhibitors in normal individuals who don't have hemophilia. They can be spontaneous inhibitors. Or sometimes we see what we call non-specific in that they're not directed against a specific factor, like a lupus anticoagulant. And we have some technical considerations in the lab that are important to us, but I'll skip that for now. The other thing that's very important that we do is we incubate the mixing study depending on how the first mix looks. And so what we do is we let it sit for an hour and we compare it to a control. So what we'll do is we want to control for the hour on the bench that these samples sit. So we'll let the patient and normal plasma sample just sit out for an hour and then mix them, or we'll mix them and let them sit out for an hour, and then we compare these two. And it turns out if there's a time dependency, some of these inhibitors are time dependent, and they won't really show themselves unless you let it sit for an hour. And you'll see a big difference between these two if that is the case. That's really important for us in the lab. And it turns out, specifically for factor VIII inhibitors, they are often time dependent. So what you'll see is your PTT will be quite elevated. It won't quite correct on the normal plasma mix. And then compared to the control, the incubated mix will be very different, as in this case. And that's actually what happened here. So it turned out, and the techs already had an idea of what may be going on. They're really good at looking at the clotting curves in the lab, actually, and recognizing patterns. And they sort of already knew what was going on before we even did all this. But it turns out that this lady had a very low factor VIII activity, normal 9 and 11. And that's important because this helps us distinguish from, say, other processes that might affect the factor VIII activity, whether it's a sampling error or whatnot, or a transport error, because factor VIII is very labile. So and just a review of what might cause a low factor VIII. This is a young lady, so it's probably not hemophilia A. She could be a carrier, but carriers don't have VIII activities that low. It's probably not von Willebrand disease because you wouldn't present this way. Doesn't make sense. And it turns out, and I'll probably, here it is. It turns out she has a factor VIII inhibitor. So this is a lady with a factor VIII inhibitor. And so it's an acquired hemophilia, an uncommon thing in general, but we see it actually quite often in our lab because we're a reference lab. So we're getting the sort of the strangest of the strange cases. But this can be life-threatening, and it can happen both with certain conditions like autoimmune diseases, malignancy, but also just spontaneously. And in this case, it was postpartum. So it turns out she was bleeding postpartum, and it was due to an acquired hemophilia. And I have one more case, but I'll probably skip it. But just a short summary. The other thing we see maybe once every 2 months or so is a non-specific inhibitor that's not a lupus anticoagulant. It's not a drug, but it's a monoclonal gammopathy. And it turns out these monoclonal gammopathies that you might see with MGUS or multiple myeloma or Waldenstrom's can really disrupt our in vitro clotting in ways that we can't predict. It always looks different from patient to patient. And this just turns out to be a patient that locally they could not figure out what was going on with the PT and PTT. They were getting wacky results every time I think they did have a couple of factor activities that they could run. And they just couldn't figure it out. So they sent it to us. And our techs kind of had the sense right away that it was a non-specific inhibitor. And it did turn out that this patient had actually MGUS. And very nice case because the doctor actually wrote me a note and kind of told me what was going on with the patient and thanked me for kind of helping clear up what was going on with the PT. And actually, a lot of these corrected as they performed chemotherapy. So again, just a slide to emphasize how important that clinical discussion is. And we've suggested SPEPs to clients in the past where we kind of help make the diagnosis of MGUS before they realized that was going on. So this is just a little review of some of our panels. I've hit on a few of our most common, but obviously we have many panels in the coagulation lab. And Joshua has the ability to reach out to us and his counterpart on our side to help you if you need help with ordering these panels as you go forward. So I'll leave it there for any questions in the last few minutes, and I know Joshua has a few slides as well. And Joshua, I can go over a little bit past the top of the hour, no big deal.
Okay, excellent. Thank you, Dr. Poirier, for that insightful information. That was really, really informative. I guess we can just do I don't want to keep you too long because I know we're getting close to the time constraint, even if you are able to go over a little bit. I'll ask that if there are any questions from the attendees, that you just feel free to please email the questions you might have to info@avexiadiagnostics.com, or you can also use the Ask the Doctor support. And Dr. Poirier, if you want to go ahead and click to the next slide there. So again, just a reminder that we've got the Ask the Doctor. It's a free service that we offer. Dr. Sedano is available to address any questions you might have about patient scenarios, results, or testing like this coagulation testing that Dr. Poirier has presented on. And now that you've learned about the benefits and clinical value that these tests offer, let's briefly review how to order them through our platform. So Dr. Poirier, if you want to go ahead and advance to the next one. Very straightforward, simple process. First, of course, you'd log into your Avexia account. You would click the Avexia link lab orders option on the left-hand side of the dashboard once you're logged in. Next, you would select your intended patient or add a new patient, create a new patient if you need to. Then you would click Add New Order, select Add a LabCorp test to order, search for the desired testing. You can do that with there's a really convenient search box, so you can start to type in the type of testing that you're looking for. It'll bring up the results. And then finally, you would just preview and confirm your order once it's been added to the cart and click Place Order. Very straightforward. Dr. Poirier, if you want to go ahead and advance to the next slide. So this is our contact details. Again, we're always happy to assist you with any questions or issues that you may have, and we can be reached during our normal business hours between 8 a.m. and 8 p.m. Eastern Time at 888-852-2723, Monday through Friday. Of course, you can always contact us anytime via email at info@avexiadiagnostics.com. And if you want, we can see if there are any brief questions. I don't see any on the board right now, Dr. Poirier. Dr. Sedano, I know that you're with us. Is there anything in particular that you want to share or underscore with what Dr. Poirier has presented?
Doc, you did a wonderful job. I will comment on the pearls. I got Earl the Pearl Monroe, Mini Pearl, and I don't know who the guitar belongs to.
Oh, that's just mother of pearl inlay.
Okay, all right. Doc, thank you so much. This was extremely.
I'll count that. That's really good. You got Mini Pearl.
Okay.
That's the one that usually throws everybody from here.
So that's probably the reason for that. But this is a very complicated. I have one question. I know you got to run. Years ago, we learned about the intrinsic and extrinsic pathways and then the common pathway. There seems like there's such crossover these days. Can you just address that with what you're doing? Is that correct?
Well, I think we still use that terminology because, like I say, in vitro, it's still useful.
Okay.
In the sense that because of the way that the clotting is activated, the sensitivity to the screening assay just turns out to be sensitive to quote unquote the intrinsic and extrinsic. And the reason it's called extrinsic is because of that tissue factor release.
Right.
So it's kind of a weird combination of in vivo and in vitro concepts, but it's called extrinsic because the tissue factor, once released from that extrinsic space, binds to factor 7, and then we're replicating that with the PT assay. And the reason that it's sensitive to factor 7 and really doesn't care about 8, 9, and 11 is that the tissue factor reagent that we're using essentially in the lab interacts with factor 7 and overwhelms. It activates factor 10 and 5.
Right.
To such a level you don't even need the 8, 9, and 11. Doesn't matter at all.
Understood.
And that's a quirk of the testing. But obviously you need 8, as we know, because a hemophilia A patient will bleed.
Right.
So and then on the PTT side, 8, 9, and 11 are quote unquote intrinsic because they don't rely on tissue factor that's extrinsic. It's not great terminology, but we still use it because colloquially it's sort of useful when talking about these things.
I was just reading in the literature about this and how that it's good to separate it out, but in I guess like you said in vivo maybe a tad different, but in vitro that's what you need to do. So Doc, thank you so much.
That's right. Yeah, you bet. Real pleasure to be here. Thank you.
Thank you so much for your time, Dr. Poirier, and sharing your insight and knowledge with us. And thank you again to all of you joining us for this webinar event. Until next time, from everyone at Avexia Diagnostics, stay healthy, stay safe, and we wish you all the best on your pathway to wellness. Take care, everyone.